My name is Dr Panofina. I'm the current sitting president of the ANMS, and it's my pleasure tonight to welcome you to our virtual session. Just a few reminders for those of you who've been watching the slides progress across the screen. We want to remind you about our clinical course, the 2022 ANMS annual meeting that will be in Philadelphia on August 5th and 7th. And we also want to remind everybody that we are having a Young Investigator Forum. Also want to remind everybody too that, as you saw on the slides, we've developed a very robust curriculum, virtual curriculum throughout the year. And these will continue with both our basic science and clinical symposia. So keep a lookout for those particular sessions. Now tonight, our session is really something that's a little bit more unique and really revolves around how do we set up a motility lab. And really, I can't think of two better people to do this tonight. And I'm going to introduce our first speaker, Dr. Satish Rao, who really doesn't need a real, highlighted bio. But for those of you who don't know Satish, which I doubt many of you don't know him, he really is a powerhouse in motility. He's essentially won every award possible in terms of motility, and has really been a pioneer in many aspects. He's one of the few people, I think, that has actually done stuff in both the esophagus at such a high level and the lower GI tract. It's really amazing because I still quote many of his esophageal papers, which I think people don't remember, Satish, that you were really an esophagologist at heart. But without further ado, I really, I could sit here and list all his accomplishments, where he's been and what his accolades are. But really, I think the most important thing that everybody knows is that he's an amazing teacher, educator, and really one of the biggest advocates for motility education there is in the United States currently. So without further ado, I can't think of any more nice things to say about you, Satish, but you're the best, and I look forward to this talk tonight.
Thank you, John. Thank you for that very generous introduction. It's really a pleasure and an honor to be invited to moderate this session. We really have a very exciting session for all of you today. As John mentioned, neurogastroenterology motility has been at the heart of my work over the last 3 decades. And it's nice to see how far it's come, and I can see a very, very bright future for this. But the hub and the centerpiece of this whole action, at least for almost all the clinicians, is really our motility lab. Now, once upon a time, this motility lab was really a small closet in the endoscopy room. Endoscopy nurses would once in a week, once in a month, they would just pull out this closet and pull out the equipment and maybe do an esophageal manometry or an anorectal manometry. Gone are those days. Now we have, well-established, well-fledged labs up and down the country, but still, there is a really lack of knowledge on how to really go about organizing and setting up such a lab. What are the tools you need? What are the things you should be thinking about? There are a few areas of equipment that are available to us. And then how do you do this in a systematic, methodical way? And so this has been a searching question. Many times I keep getting emails about this. People are writing and people are listening, really thirsting for this knowledge. So to lead today's topic and to give us some firsthand knowledge based on personal experience, we have Jason Baker. Jason is currently the Director of Research in the Motility Lab, as well as a person who's really organized the entire Motility Lab in 2 different cities. He initially was with Bill Che at the University of Michigan, and now he's at the Atrium, Wake Forest University. And he has done a great job, not only in the Atrium Center, but he's really also helped develop some community programs where motility tests are being done. So I think it is truly a pleasure, Jason, to have you speak on this topic, which is so close to your heart, something that you have worked diligently for several years now. And really, you've just written a very nice paper that may be just in print or likely to come up for. So as a follow-up, I think some of you may want to read Jason's article that should be out in current gastroenterology reports momentarily that really kind of conceptualizes how to organize and develop a motility lab in the academic practice as well as in the community. So off to you, Jason. I look forward to the presentation. And for many of you who have questions, please go ahead and use the share the questions, raising your hand, etc. We'll try and address some of those questions. If not, we will deal with them in ANMS Doc Matters later. Thank you.
Well, thank you, Dr. Rao, Dr. Panofina, for the kind introduction. Yeah, this has been a labor of love for me for about 20 years, and I've had great mentorship, including both Dr. Rao and Panofina and Dr. Shea. And a guy named John Whalen really took me under his wing as an architect of a laboratory operation back in early 2001 when this all started for me. I'd like to first start appreciating everybody that is listening. I think this, hopefully we could provide basically a plan of how to develop a laboratory, either if you're starting from scratch or you got a current operation going, or if you're looking to expand in the future. My disclosure is enough for this presentation. So some objectives, like why do we want to develop a motility lab? And there's some nomenclature across the country that they're all a little bit of the same thing: motility laboratory, GI physiology laboratory, neurogastroenterology and motility laboratory. As you expand the lab, it's really a GI physiology laboratory to a neurogastroenterology motility laboratory. But for this presentation, just for limiting the words, we're going to use motility laboratory, but you should look into moving on to a more sophisticated name as you reinvent, develop, or expand your current operation. We're going to review some strategic components that are necessary for the development of this type of operation. The nomenclature I would recommend moving to more of a appropriate name for this type of laboratory, some strategic components, and really what I believe is really the importance of it all, empowering all teammates, because everybody's going to look at it a little bit different from a different perspective. And going back to my favorite movie, Dead Poet Society, Robin Williams stands on the desk and has everybody does that, and they look down and they all see a similar thing from a different perspective. So when I think about developing a laboratory, and I've had the blessing to help be partner developing, either from something that's space has already existed, to reinventing space, to actually helping dig the shovel when the ground was nothing there but dirt. So I played a role all through different aspects. Each project is a little bit different, but in a lot of ways you become like an architect. The definition of an architect is a person or a team or who designs and guides a plan or an undertaking. So years and years ago, I took this wonderful excursion of an architect tour down the Chicago River through Chicago. All the buildings are similar, but they're all different. They all have a meaning. They're different shapes, they're different sizes. They all represent something differently. And similarly, this is what happens when you're developing one of these laboratories. And in architecture, there's really three main elements. There's a meaning. Why are you actually doing this? What is your vision? What is your short-term vision to your long-term vision for this architecture project? What is the function? Is it an open lab? Is it a closed lab? Is it for a small group? Is it for external stakeholders, partnering and marketing to different disciplines of medicine at your own institution? And what form? Like, is it a single room? Is it a part-time room? Is it going to be a full-time lab? Is it going to be multiple rooms? Is it going to be satellite based? Is it going to be a heat map study from all over a state or a region, isolating back to one? So, but they all are interconnected. Each can't function without the other, similar to these buildings, like as you see down in Chicago here. So I've been working on a definition of a motility laboratory for many years. It's taken several iterations, but over the last 5 years, I kind of stuck on this one. And how I define it is a dynamic laboratory which provides diagnostic testing to assess, identify and evaluate physiological motility patterns and pathophysiology of functional GI disorders, utilizing contemporary technology to challenge traditional theories. So I think within one of these laboratories, it has the possibility to do all these. And as you develop it, you can develop into a clinical operation, you can develop into a biomedical operation, you can also develop into a research opportunities for residents, fellows, teammate members, other faculty members, visiting professors, all these type of things, and they all interconnect with each other to expand the team's presence. So as a kid, my mom used to put Lincoln logs down on a sheet for me, and I would just, for some reason, just count logs and build logs and knock it over, count them again, build it again. So in a lot of ways, I look at a laboratory the exact same way. They're building blocks, and you can start small and build big, or if you have the opportunity to build big all at once, but there's cornerstones. And I consider like these are the 4 big blocks, starting with manometric testing and pH testing. It's the most referral-based one. It's the best economic model. Then you got breath testing, you got new video technology. Then when you get into more of the sophisticated labs, you can use some secretion testing, Baristat, EGGs, and other type of therapies along the way. And eventually you get this comprehensive type of motility laboratory, all building the blocks as similar as an architect. So why develop a motility lab? Really, there's a significant proportion of patients who experience at least one functional GI disorder, and they based in the categories of esophageal, gastroduodenal, bowel, anorectal, and they all have these symptoms that filter into a laboratory to help patients find some reasons why something may be happening, or at least rule some stuff out and potentially lead to the right interventions or right conversations with the people to help them limit these type of symptoms, like dysphagia, GERD, IBS type symptoms, constipation, bacterial overgrowth, fecal incontinence, food intolerances, dyspepsia, gastroparesis, all these types of symptoms. There's a potential that a lab like this could at least provide some help for patients to find some help to move on to get better quality of life, because these patients often experience and report lower quality of lives. They get in this turn cycle type of thing where they see physician after physician after physician, all seeking to try to find answers for their symptoms. A lot of times the symptoms are overlapping. And really in 2019, there's a team Dr. Yattopalli led to, showing that basically there's only roughly about 120 of these laboratories in the United States, which is not enough to help a growing patient base find some answers. Recently, the Rome Global Foundation did a large internet study, and over 54,000 respondents from all over the globe. And if you look at the burgundy type of areas, these are people that within the respondents indicated that they at least experience one functional GI disorder symptom. So it's amazing how many people experience this and how many limited number of labs we actually have in the US. So these are some strategic components that I've experienced and I found helpful along my journey with the great mentorship of the people that I mentioned before. So I think there's space configuration. People don't really think about the space configuration too much. Personnel and staffing, cleaning the procedure and sterilization, which is really important for standardization, limit cross-contamination, and also limiting repairs. How do you train a motility laboratory staff? That's often a question I get quite often. The dissemination plan, people don't really think about the dissemination plan. Even you do the test, but how do you disseminate it to the ordering provider? Technology as simulation, especially as diffusion of innovation theory, as new technology comes and other technology plateaus. Billing process is very important. Then I'm a big proponent on developing an economic model. So space configuration, it's similar to like going back to the architect metaphor, is that what does a space tend to look like? There's really no documented information on how big a motility laboratory room or unit should look like. But if you go to the endoscopic literature, it's roughly 160 to 300 square foot. This square footage allows you to have safety for the patient and not allow the patient walk into a room and think they're walking into a closet. You want them to feel comfortable when they walk in the room. A lot of these tests may be a little are intimate. Other ones, you know, they're being transnasally intubated for the first time with no sedation. So there's some anxiety levels. So you want the room to look fresh, and you want to some airiness in the room. Other things you need in there, you know, oxygen capability, just in case of adverse events, adequate power, and power outlets. You should have at least one outlet that's backed up by a generator, just in case you live in an area that has some power outage, so you're not doing a test and you lose everything and have to take the catheter back out and start all over again. And as we live in this, you know, our time, is that data outlets are very, very important. So a sink, you need a sink in there. Most places only allow for one sink. So there's a plexiglass separation. As you've probably seen through the pandemic now, you walk into any place now, there's a plexiglass between you and the customer service person of the store you're in. But similar type of thing is in a lab. You want this plexiglass separating the sink from other work areas or patient type of catheter is going to go in there, or paperwork because of cross-contamination. You need a staff assistance buttons, just in the rare chance there's an adverse event. Then you want ample cabinet storage, but some of the cabinets should be ventilated to allow the catheters to have ample drying capabilities. So this is from Dr. Curtin. He was on that paper that Dr. Rao was talking about during the introduction. He's at Mercy Medical Center, and this image was supplied by them, but he was blessed with the opportunity after developing a business plan to actually develop a large one of these motility labs. And as you see, this is the schematic drawing, very similar to one we did in Michigan, Dr. Shea and I did, but you can see how everything is laid out comfortably, where the egresses are both important. We're going to talk about egress in a minute. When you schematically draw a room, the bathrooms on the lower left-hand corner for the lower motility have separate bathrooms. You have a work area, you got some storage, it's really important. Then the breath test bays. Similar when you're buying a house, there's a John Whalen who mentored me during my first project. What we did is we staged the area that we were developing. We used blue painter's tape. So if you're developing a lab and you got a new area, or you're reinventing another area, stage it. Similar if you're building, you know, selling a house, you want to stage the area so you know exactly what it's looking at. Have all your teammates come in there, stand where they were going to stand, and make sure the flow is safe and adequate. So the plexiglass, this is a study done, you know, looking at infection control, but this is a special type of moisture detection paper. And they did a study looking at, when you're at a sink, how far does the droplets move? So if you think about it, if you look at all these different areas, they put some on the backsplash, they put some on the counter in between, next to it, to the left, to the right, on the person itself. Dispersed droplets from the water come out of that sink when you're washing your hands or you're doing whatever you're in the sink. It can move from 3 to 5 feet. So that plexiglass right next to it protects that droplet splash or disbursement to cross-contaminate in another area. And this got brought up actually in a JACO review. We called FACO, but a review by our internal policy. And we actually tested it, and we found how far the splash went by turning the sink all the way on and putting our hands under here. So I would recommend, it's a very inexpensive project. Most of the time, building engineers can do it in about 10-15 minutes, but it also protects and improves patient safety and infection control. So the means of egress, and egress means the ability to move out of one room to another. There's a clinical impact to this, and I have a personal story that happened to a lab at one time. We had a patient and we had the room set up, and we never really thought about egress, the clinical impact and the safety impact of it all. But a patient got super nervous, and it was a female performing the study. It was a male patient, and during the anxiety of it, he kind of jumped off and he was standing in front of the door, and eventually everything calmed down. But during this situation, we had a chance to review our process. And we actually partnered with our local security, and we did a walkthrough, and we found out how we had our equipment and our like stretcher chair set up. It did not provide safety for our staff, just in case there was an adverse event that could provide a more of an unsafe event occurring. So we changed everything, but by JACO and CMS, what they really look for is egress integrity, is the door cannot be locked from the inside out, and the corridor must remain clear. So when you're having your review, these are two things they're going to look at that egress. But the reason for this is really fire safety, employee safety, patient safety, and it allows you to not get a citation when you're having your review by whoever reviews your lab. So personnel and staffing. This is really the pivotal portion, I think, when you're developing your lab. Currently, there's no national motility laboratory certification. I get that quite a bit, but then it comes down, how are the staff members being trained? There's a plethora of reasons. Most of the time, it's a Venn diagram in a lot of ways. Faculty members sometimes trains people, peer-to-peer, manufacturer of clinical support people or sales representatives. Sometimes they're self-study or Google searching. There's seminars by the manufacturers that people go for in the weekend. There's workshops, there's the ANMS meetings, but ultimately there's many different ways that are occurring. And I think they're all good. They all have some positivity, but we're going to present basically a diagram. What I believe that basically is how the right way to train someone, and it's been really fruitful for me over the years. The knowledge requirement, there was back in 2014, SG&A published the knowledge requirement to do these type of testing. And basically it was very simple. They must demonstrate knowledge of the relevant anatomy and physiology and skills to perform the various diagnostic tests. Very vague. So around the country, there's a variety of people who perform these tests. There's medical assistants, there's technicians and technologists, nurses, advanced practice providers, there's actually faculty, there's fellows, there's advanced fellows that are in motility, kind of all do this. There's a lot of different people doing laboratory type testing. The basic responsibilities of someone working in this lab are, being able to educate a patient, maintaining quality controls of both the equipment and all the catheters, performing the diagnostic procedure, preparing the acquired data for interpretation. That's the editing and reviewing. But regarding the intubation part, transnasally or transanally, is that really lab personnel should follow the state and intra policy who's able to do this, and different states have different requirements along with the intra policy of the healthcare center that you're actually in. So the next strategic component is really cleaning and sterilization. Really the key factor is that a laboratory leadership should partner with a local infection control specialist. They'll see it from a totally different perspective. But partnering with them, there's education brought by both sides. And this is able to formulate a strategy for disinfecting the catheters and equipment in a very standardized formation and process. So obviously there's the manufacturer's IFU that is very, very important. All the steps need to be followed. There's also some intra-policy recommendations about the flow, the directionality, where it's being done at. Some people have this transported to a hospital base. Some people have some local infection control. Some are central. All that, some intra-policy recommendations. But ultimately, the manometry catheters are actually considered semi-critical items. That means they contact mucosal membranes and non-intact skin, in the nasal passage and in the anal rectum. So that means it needs to be high-level disinfectant. So there's different strategies depending on the type of catheter that you're using. If it's high resolution, it needs to go through the whole process of the infection control. But if you're using disposable, sometimes when you're developing labs and satellite labs, you may have different equipment at different areas. The disposable ones, manometry ones, balloon expulsion catheters, pH ones, they can be disposed in a trash in a red bag in a trash can. So there's different ways, and partnering with this infection control specialist, you can formulate a plan and ultimately be ready for your JCO visit and show that how your plan is moving throughout the whole process. This is a very effective model that we've employed at all the centers I've been at, is we call the red-green model. Again, staying with consistency within the endoscopy process, which is really important because a lot of these labs end up in an endoscopy center. The more you're consistent with what you can be consistent with endoscopy procedures and processes, makes the whole unit and the whole operation flow a little bit easier. So there's very inexpensive way, like these coverings here, as you see on the bottom. Red means dirty, green means clean. They also have these big symbols. So another indicator to show you what it is. This color system really limits the amount of cross-contamination that may occur. So maybe limit or eliminating even the portion of using a non-disinfected catheter on a patient because the process wasn't completed. The infection prevention thing, there's education, there's many different forms of education, but I suggest biannual education seminars or little breakfast things or coffee breaks to just talk about the infection control process. Training, again, biannual training checkoff list is really important, especially when you get new staff in. Every time you have a new staff in, I think the whole staff should go through it just to be as a team effort, a team working effort. So everybody's on the same page, everybody feels inclusive. Then standardization between an endoscopy procedure process and the lab is really important to help move the process along, especially as teammates come and go and leaders come and go. So often people ask me, what is the key component of making a motility lab basically prosper longitudinally? And I really think it's the longevity of motility staff. You won't get all staff to stick around, but if you can get a portion of your staff to have long longevity, they become really the pillars, the cornerstones of the proctors, the mentors for newer staff coming in. And I'm a big person on a model of having cornerstone people looking to go to medical school and PA school and MP school, people going to business school, all play a role, having short-term time in the lab, like 1 or 2 years, but developing a cornerstone of people is really, really important. And I think how you do that is empowering these staff members to partner with all the operations. I'm a big believer on trying to, encourage them, be advocates for them, our independent thought, being a part of research projects, implementing new technology, being a champion for new technology, being part of the business, part of the operation, teaching, whatever it may be, quality control projects, leadership ladder inside an organization. And also all members should have a role or a voice in the future vision of the staff, because everybody's going to, in the laboratory, because everybody's going to see it from a different perspective, and including everybody's voice strengthens that vision throughout time, and really basically provides a map to implementing that vision. Constructing a partnership environment. Like I said, all teammates have an equal amount of voice inside the Motility Lab's direction. In some ways of empowering staff, I'm a big proponent on is leaders of the lab should really advocate for, travel funds for these staff members, or at least a couple of the staff members, to go to like the ANMS annual meeting to basically bring back what they learned so they can teach all the teammates about what they learned and the conversations they learn about other people may be doing a little bit different that will improve the operation. But more, and another important thing is the impact of limited motility staff employment. So there was a study done by the Institute for the Future of Aging Service looking at long-term care services, but I really think it employs here also. When staff come and go, and it's kind of like a revolving door, at the enterprise level, at the healthcare system level, there's a big cost, direct and indirect. There's a lack of productivity that's going to occur out of the lab. There's time to interview people, train people. All that is at the enterprise level, which impacts the enterprise level. Then at the service level, really the patients who are coming to these laboratories are more than likely going to get these tests done by less experienced staff members and potentially lower quality of testing throughout this lab because just of the experience level they may have. Then the third party level really is the stakeholders who are referring into the motility laboratory service, surgeons, external providers, APPs of different disciplines. All basically, the testing they get back and the results they get back could be impacted by having a lack of longevity. So try to empower your staff as much as possible and include them on everything to try to build a cornerstone of staff to help with the longevity and proctoring as time goes on. So this was something I developed about over a decade ago now, and I really think it's the right way to train people when you hire them inside your laboratory. It's a lot of words on here. I'm just going to kind of talk through this, but the first stage is this observation phase. A lot of times when you get the people in the observation phase, they think it's a little bit of a waste of time. They're not really doing anything, but I really encourage them to really watch, not so much to get to know how to do the test, but how people stand, how a more experienced person talks to the patient, how they make them feel, how they welcome them into the room, how they walk them out and thank them for, choosing that healthcare center for, providing care, all that type of stuff, how they set the table up, how they set the equipment up, how they break it down. All that is very important and how they do that. Then the next step is this like one-on-one shadowing phase where the trainee starts talking to the patient, starts going to get them, doing some things like the beginning stages of the process, walking them out, explaining them how the procedure is going to go, the consent, all that type of thing, maybe the start of the intubation process, maybe doing without touching the computer. The next step is a semi-independent phase. Now now the trainer is just starting to leave the room a little bit more. This person's starting to do it on themselves a little bit, but the trainer is outside on hand for that trainee at any time they need help to work through any type of thing that's going on with the test. And then the last step is when they're in this independent phase. Now they're actually doing everything by themselves. They're in the room by themselves, and the trainer is a little bit more distant, but they're still available if needed. But after each one of these phases, there's like this dialogue that happens between the trainer and trainee, what we can learn, some constructive learning, what we can do a little bit better. What did you see? What did I see? What do you think are some hurdles that you need to get over? What are some challenges? This is what you did good. All this little dialogue with checkoff lists after each one of these stages. And this should be done for each one of the laboratory tests. Some tests will go a little bit faster, like breath testing. Some will be a little bit longer, like manometric testing. But if you do this, it's like hitting a curveball. If you learn to hit a curveball the right way first, instead of stepping towards first or third, depending if you're right or left-handed, if you're always stepping towards the pitcher, when you're by yourself, you'll retreat back to the proper way of doing things when real-time adjustments need to be made. So this is a thing I've employed for staff members, visiting people that visit the lab, fellows, residents who have wanted to learn how to do this, APPs. And I encourage people to try to implement a very similar process. So the next stage, this often gets overlooked. So you're getting referrals in, but really we want to provide great patient care. We want the patients to feel comfortable. We also want the external providers or the people sending referrals over to have the same high quality experience. So when you're developing your lab or you're looking at how you can make it a little bit better, this is a good flow of how to do this. And you should actually walk through this with all your teammates and find an external provider to try to do this and see if there's any hiccups or challenges that need to be worked out. So the first part is, acquiring the motility laboratory data, but it really starts a little bit before that. So you want to provide whoever's referring into these the right referral, either paper or electronic. You want to give them the instructions of each individual lab, like the medications, when the MPO, all that type of stuff. Every lab's a little bit different. How they go about doing that, instructions for all the tests, so they're able to have that when they're referring a patient to your lab. So during the acquirement of the data, you want to get the required documentations. For example, you may want, for esophageal manometry, you may want the most recent EGD, esophagram, anything else that you may want. But you want all that sent over before the test, before you start the test, so you can prepare the night before of the patient coming in. So all that, then the next stage, you're going to basically, after the interpretation of it, it's all adjudicated by the provider, interpreting provider, they populate a report, and then you're going to provide the interpretation, but then you're going to disseminate it. So you want to make sure you know how you're disseminated to all people, electronically, faxing, however it may be. So everybody gets in a timely fashion. So you also want to make a timeline. This all should be done within 7 days, 14 days, 10 days, whatever it may be, and try to stick within that guideline. So whoever's ordering there could also be very clear when they're going to expect the report back, because that's also going to limit the amount of phone calls back to the interpreting provider's team. So technology assimilation is really important in this particular space, because new technology is coming and going quite frequently throughout this space. And it's very exciting, I believe, and it's very exciting for the staff to learn how to do different things and be a part of this new technology. But you want to prioritize what your technology investment is. You want to know what your space allocation is from now and what it could potentially be. Who are your stakeholders inside your own healthcare center, outside your healthcare center? So you may want to do some focus group, phone calls. Then staffing issues. Are you going to have full-time people? Are you going to have part-time? Are you going to be sharing staff? All that goes about to know these things when you're, when you're making a technology investment, because this is a sometimes very expensive upfront investment. And then when you're making your business plan, you want to have your 1, 3, 5 year technology plan, because this is, as you work your way through this, you want to have a pretty good game plan as you're working with your partnering with your business analysts or your business manager inside your own healthcare system. This is what I'm looking to do in 1 to 3 or 5 years. This is what I expect the cost will be. What does the community need? Is there a lot of bariatric surgeons moving to the areas, or what you just want to know what your community base, is there a lot of colorectal surgeons in your area? You want to know what's in your community, what their needs may be. Then what type of internal expertise you have. For example, you may not have an esophagologist or anorectal physiologist or a small bowel person. So looking to invest in that technology plan may not be the best use of those resources until you invest into that expertise to provide the best interpretation for those type of tests. Esophageal manometry, it's really the cornerstone, I believe, of the starting of any of these physiology labs, and it really provides adjudication to esophagograms of the major swallowing disorder of echolasia. So this is one of the studies, is really the cornerstone when you're starting to develop your lab. Same with anal rectal manometry. There's been many different catheters around over the years. As you see down the lower left hand, this is someone trying to squeeze. So really kind of evaluate what's occurring in the anal rectum, basically during constipation and fecal incontinence and anal pain. And there's many different modes to how to do that, what you want to invest in. Then there's hydrogen breath testing. The schematic basically of seeing the fermentation of a carbohydrate to value for small intestinal bacteria overgrowth, and then also carbohydrate fermentations of lactose deficiency, sucrose, and fructose. All are very important to help these people figure out why they may be having these type of symptomology. So all three are cornerstones when you start to develop your lab. Dr. Lee and Dr. Rao early in 2020 developed a tier system, which is really, I think, is a very well done when you're developing your lab. What should be in tier 1, tier 2, tier 3, as you develop your operation from basically a basic type thing to more of a intervention or more of a expansion to your laboratory operation, what you can potentially offer. So the pillars of tier 1 is, when you're looking to your investment for your technology investment, esophageal manometry and pH testing. You can see the indications here, very common where people going to see gastroenterologists. There's many different manufacturers for all these. Anal rectal manometry, there's different modes from high resolution, 3D, water or air charge, disposable ones, again, for all very common things seen by gastroenterologists: constipation, fecal incontinence, and anal pain, surgical base, breath testing, very common. And then wireless motility capsule falls into this tier 1 when you're looking to invest. Not that you have to have all these if you're just starting your lab, but I would highly recommend definitely the esophageal pH, esophageal manometry, pH, and anal rectal manometry, and breath testing to make a original financial investment. Then the next tier 2, is you start to get a little bit more sophisticated. Again, there's many different things here that you want to think about before you invest in this. Is that, do you have the local expertise to actually interpret it, which I think is very, very important. A partnership with an endoscopy like EndoFlip, there's maybe some, you can share the equipment and split the cost, which will help with, the business plan and the return on investment. But overall, these are other things you can do. Very similar, colonic manometry doesn't really bring back very much an ROI, but if you start talking to colorectal surgeon and you even partner with pediatrics, which do more of these, you may be able to provide a service inside the lab that another discipline may find useful, and you may not even have to worry about if you have a local expertise, because a pediatric may have that local expertise. Same with anteroduodenal manometry. So this is the next tier of testing as you expand your lab if you want to move forward. Then tier 3 is a little bit more of highly specialized or interventional, like the biofeedback type of thing, and then different type of neuromodulation therapy. But with the biofeedback, I do want to mention, make sure you partner with a billing specialist who's required to be in the room during this type of testing, biofeedback, because it has changed over recently. So you want to make sure you partner with them, make sure you have the teammate responsible that can provide the right billing for this type of procedure. Or if you have a lot of anal rectal manometry, there's operations now are looking to build a business plan to hire their own pelvic floor physical therapists to be part of the team to provide this type of care within your laboratory operation. So billing strategy is very important. I think the laboratory leadership team should partner with local billing specialists. If you're starting, or if you want to make sure if you're already in operation, you want to make sure everything is up to code. So basically, you want to develop this rigorous billing strategy, because this really is the pivotal when you want to go invest and expand. You want to provide evidence that you are economically fruitful. So you want to construct a really good pre-authorization process. You want to find out who your top 2 insurers are and work with them to make sure they get all information they need when you're providing it. And they're willing, if you call them, to provide this information and give you some education, what you may need. They accurately designate your service code. This is basically where it's done. Is it office space? Is it off-campus hospital or on-campus hospital outpatient? You want to identify that all appropriate CPT codes are employed for your procedures in the lab. You want to, again, partner with the billing expert, but make sure proper utilization of the modifier 26. For example, when a wireless pH capsule is attached during endoscopy, the interpretation comes back. You want to make sure you put the modifier 26 on there so the physician interpreting the test gets the revenue for that. So working with an expert is very, very important to work through these type of things so you're billing appropriately. The next is physician office based. Basically, there's a global fee. That's basically the physician owns the equipment, does the analysis, interpretation, all in the same setting. Then the hospital base has 2 modifiers: the technical component, which basically goes on to the hospital expense, and then the physician component, which is the modifier 26, basically is the cost for a physician to interpret the study. And as you see here, these are national averages relative to Medicare, related to the codes that are often employed inside of a motility laboratory. The costs are really relatively similar between the global and the professional technical component combination. You see the RVUs on the far right-hand side for physicians, but recently, Dr. Mosher and I had a lot of conversations with our billing expert at Atrium, especially with 91037. I'm just going to use it as an example. When you're working through it, part of the things you want to talk to with your billing specialist is make sure that your note incorporates all the very important aspects of each individual code. So for example, in 91037, inside the note, it must say something about reflux. And if it doesn't, it's really out of code if you ever got audited. So as you work through the description of here, when you're creating your smart phrase or your common note that you use, meet with a billing specialist, especially a CMS specialist at your local institution, and just show them the note and show them the descriptions of all these codes and ask them, is this note appropriate for this code, or do I need to add something to make sure if we get audited, we are all on the same page. Here are some other codes, the exact same thing. Make sure that, again, that your note matches the criteria for this specific description for this test. And again, these are very similar throughout. As you see, there's some things like have a component, no global code, such as the colon manometry, because that's going to be done, or colon motility test, that's going to be done inside of an outpatient hospital center. So economics, often this gets overlooked. And I think, especially with the ability, everybody's generally billing inside of an EMR system now. There's many different softwares out there that institutions invest in, but there's ability to extract this data. And if, as a motility lab leader, meeting with a business specialist to say what you exactly want, a lot of times they can populate this for you. It takes a little bit of time. It took about a year at Atrium to get the data that we actually were requiring. And at Michigan, it did take about another year, same thing, to get the data that we needed. But after we got it, it would be populated on a biannual basis. So basically, when you're looking to build an economic motility lab economic prospectus similar to your retirement, you want to know different things. You want to examine how the economic evaluation is for the local entity, your local unit, and at the enterprise level. Are we doing good for the local place? And are we helping the overall healthcare system provide an avenue for other testing or other interventions down the line? It basically fosters a cohesion vision, a current future, as you present what your ideas are down the future. It allows you to investigate economic trends overall for the lab and which procedures are doing better, which ones are not doing as good, especially when you want to invest in new technology or new equipment. And also it provides evidence when you're building your next business proposal of having real data, not speculated data. You have real data, you have real trends. And this plays a big difference when you're sitting down in front of a committee and you're asking for X amount of dollars, or you're expanding into another healthcare system because you acquired one. Having real-time evidence really puts you a step ahead of when you're competing for these limited amount of dollars. I'm a big believer on providing a biannual motility lab, I call profit and loss statement or prospectus. It should be delivered to all teammates of the motility laboratory. Everybody from the person doing the test all the way to the director, the infection control, everybody who plays a role in this should receive this. The recommended items I've included in a profit and loss statement for probably 15 years now are these. I want to know what was the submitted bill amount. It's going to vary with different things, different negotiating, and everybody has a different negotiating price. What was the adjustment? What basically was written off, and what did we actually receive? So basically gross and net. And I want that for if it's a technical component and a professional, I want for both. If it's just a global, just a global. What is the salary of our teammates, and what is the fringe benefits costs? Supply charges, how much? So you want to basically, supplies is really good ways to find ways to save money, because this allows you to readjust inventory control. Maybe you're buying too many capsules, you're not using as many. Maybe we need to invest in more catheters, esophageal, less than anal rectal, or vice versa. Maybe we only have to invest in one type of pH catheter. All this will supply inventory management allow you to make those decisions. New equipment, if you purchase them during a quarter, repairs, if you depreciate your equipment, some people just flat out buy it, some depreciate over 3, 5, 7 years. What is space charges? Space is something I learned from industry, is that space basically is basically around $50 per test. That's your linen, that's your lights, that's your water, all those things, your gauze and all these type of things that are really hard to basically measure. So if you just, what I always use is $50 per test. Then travel costs. I'm a big advocate, a proponent of getting travel dollars for staff, 1 or 2 staff members to attend the ANMS meeting every year, because I think it ultimately improves education for the whole motility team, just not the 2 individual people attending the meeting. This is a schematic of what I've used for a long time. Of when I build this economic model, these are the data points I go after. You see Q1, Q2, 3, 4, and the total. And at the very bottom, you'll eventually be able to add all this stuff, and you'll find out if you had a profit or you had a loss. So very similar if you ran a small business, that type of thing. This is a very similar profile. And if you work with a business analyst, you show them this, you'll be able to populate the data with some good conversations along the way. And a lot of times now it's just a code that can be written inside an EMR system. So in summary, motility labs are important for providing physiologic information for functional GI disorders. More high quality laboratories are needed, especially as we age, people live longer, these symptoms tend to just continue to grow. They're very common. So we need more and more high quality laboratories. Motility laboratory development includes a diverse group of people. It should not just be one voice. It should be a global voice, inclusivity, diversity, of how to having a voice for empowerment in this laboratory expansion and operation. And if you use a strategic motility lab development plan, it enhances the possibility for consistency, standardization, and eventually growth and expansion to help more and more patients improve their quality of life. I appreciate everybody for listening, and welcome to answer any questions that you may have.
Thank you, Jason. That was an outstanding presentation. Truly, I think you covered a very large area. You went through very systematically, the rationale, why we need a motility lab today. What does a motility lab do? What are the principles in setting up a lab? What are the infrastructure needs? What are the equipment needs? What are the personnel needs? And then, really also harped on the very important, challenging question that many people face is the billing and coding requirements. What are the tools we have? And finally, you summed up nicely with the economic case and the economic models as to how people can use these kind of tools that you and others have developed so that they can develop a viable, thriving, and what should be a profitable clinical service. The important thing is this is a much needed service, but has been neglected for a very long time, and very few people have recognized it. In the GI space, endoscopy rightfully is given the space and really has the potential growth and investment in innovation and new technology. But for many, I think they've reached the max there. It's really reached its peak. So here is an opportunity to provide a broader range care, to provide better care for many patients because it's missing, and to use this knowledge for their benefit. So I think we have some great questions already here. And I think I would like to take some of them. I'll probably have you chime in with some. But Conrad Cox asked a question for ARM. Can the 91122 and the 91120 CPT codes both be billed if each of these components are performed during the test? And the answer is yes, yes, yes. And this has not been done for a very, very long time. And just so that you know that the 91120 code, I actually fought with the CPT panel and got that code issued almost 10, maybe 13 years ago. And so that was added on because we always routinely do rectal balloon sensation and compliance testing. It is important that if you're going to bill for this, you really have to have your documentation supporting what you did there. And this can be easily done with standard, high resolution manometry system that we use. So yes, if you do it, document it, you can bill for both. And remember, actually the 91120 reimbursement is even higher than the 91122. And that was because of the way we built the case for this and got it through the CPT panel. So it is good. So do so. There was a question from, let's see, Price Edwards. Jason, thank you for the great talk. Have you found interpreting tests on a different day than the day the test is performed affects billing? Do you want to take that?
Yeah, the test can be interpreted after the fact or the same day, but when you're doing the billing, the date of the study needs to be the date of the service. So if you had it done on February 1st, but you interpreted it on February 7th, on your note, it should say February 1st as the date of service. So it matches the encounter within your EMR system.
Right, but just a little twist on that, and maybe a little bit more elaboration on that, is if we do a 24-hour pH study, and that changes the equation a little bit. Do you want to elaborate on that?
Yeah, so if you do an esophageal manometry and a pH on the same day, the manometry would be the day of service, say February 1st, the catheter comes back the next day to be removed. The date of that service would be the next day, February 2nd. So they can be billed independently of each other, especially when you get in this world of, especially the word impedance is a very tricky thing. When you get into the codes, if they're billed on separate days with the right documentation inside your note, you'll have no problems, but the date of service needs to be on 2 different days.
That is the important thing, yes. So it is very important because you cannot bill for the pH when you don't even have the data. The data is only available the day after you place the probe, when the probe has come out and you have all the downloaded the data, interpreted the data. So that is when the billing should be, and it will separate, as Jason just said. But if you are doing impedance esophageal manometry, okay, remember that is different. If you're doing impedance esophageal manometry, and it is defined as impedance manometry less than an hour or something like that in the billing code, you can bill both for esophageal manometry and for the impedance manometry on the same day. And there are 2 separate codes again that you can bill and can be reimbursed for that. So that I think is important. All right, there's a question from Brian Jennybaugh. Hi, Jason, thank you for such a fantastic and informative talk. In Detroit, we are currently using home breath testing due to space and staffing constraints. What are your thoughts on accuracy of home testing? And are we losing revenue from home testing versus in-lab testing?
It's a great question. So I had the blessing to be part of the American ANMS's statement during COVID of how to operate a lab recommendations. And part of that recommendations of that documentation is to start to use an at-home breath testing, provide patient safety, staff safety during COVID. So the accuracy, we did a little intra type of thing. The accuracy was pretty consistent with what we would see if we did it inside the lab. There was some samples that the patient didn't take the tidal volume away or pull the tube too quickly. So there was a few, but not very many to say not, persuade us not to do it. So there is a way you can develop a plan. It does take 2 encounters. One is a fake encounter, one is a not. So you can have an education. They can come on one day for the education to pick up the kit. And then you don't really bill them for that type of education encounter. But the day they bring back the test, like 7 or 10 days later, whatever you want them to bring it back, the day that it's analyzed that day in your lab, you can bill for the 91065, the analyzation of that test. So you can still bill for it, but it does take a little bit of working with your EMR scheduling template people to do that. But there is a model to do that. Or these breath test companies also provide a service where they'll do the analysis themselves and send you the report.
Good, good. Conrad Cox has another question. For biofeedback, there are video game EMG models available. What experience do you have with this, and how technically demanding is it? I honestly have no clue about this video game EMG models. I don't know if Jason has, but I think, you know, there are a number of gimmicky things on biofeedback available out there. So one has to be very careful is all that I would say. You have a monkey climbing a coconut tree as a method of showing that they can increase the anal sphincter pressure, etc. But I think realistically, the challenge with biofeedback is, as Jason alluded, is who's performing it and where is it being performed now because of the recent changes in the code. That I think is a big change. And now RNs are not allowed to perform under guidance and so on. So you have to be there, or a physician assistant has to be there, or a certified nurse specialist has to be there to provide the service. Of course, if it's physical therapy, then, you know, that is built by physical therapists separately. So there are some real changes. So a physician can do it, a nurse practitioner, PA can do it, or a certified nurse specialist can do it. That's the only way we are allowed to bill for biofeedback services today. Mm-hmm. So with that, I think we are at 7 o'clock. So I will unfortunately have to close this session. Thank you all so very much for joining us. It was a delightful session, and to hear this a great presentation by Jason, and for learning everything. I do know some of you probably still have questions, and our questions coming in, and we will continue this conversation on ANMS Doc Matters. So please do chime in there, and we will answer these questions in there. If you have other questions, feel free to write to us at www.docmatter.com/ANMS, and we will continue this conversation virtually online, but we'll have to close this session. So Jason, any final thoughts?
No, I just highly encourage the importance of developing these type of laboratories around the country. They're going to be needed, and much more as patients get older, people get older, and more importantly, improving quality of life of all patients should be our primary goal.
John, over to you for the final word.
Final word is thank you very much. Enjoy the talks. Have a good night, everybody.
Thank you. Good night, John, and good night, everybody.
Thank you.